Hello and welcome to our presentation on GABA expression and ECT response in a geriatric patient with catatonic depression, a case study. The study was conducted by our team, including myself, Yevhen Pityk, PGY5 Psychiatry, Dr. Tim Lau, Dr. Reggie Taylor, and Dr. Lori Tominen. Our objectives for today are to briefly discuss the neurobiology of catatonia, the methods of our study, and the results. As we know, catatonia is diagnosed with 3 or more of the following symptoms. I will not go through the list in the interest of time. So catatonia was originally described as a separate entity. For nearly all of the 20th century, it had been considered a phenomenon associated with dementia praecox, which later became known as schizophrenia. Only in the last 2 decades, it had once again been recognized as an independent entity. The exact mechanism of catatonia is unknown at this time, but the orbitofrontal cortex, the ventromedial prefrontal cortex, and the dorsolateral prefrontal cortex have been implicated in its mechanism. Now let's move on to discuss the patient in our study. He was a high-functioning, at baseline, 80-year-old male. He had no previous psychiatric history. He was living independently with his wife, and he was also independent for both basic and instrumental activities of daily living. He presented with major depressive disorder with psychotic features. He was found to have catatonia. The medical workup was normal. The cognitive testing revealed a MoCA of 11 out of 30. However, his decline was quite sudden, which suggested that this is rather the result of his depression rather than dementia. And we treated him with ECT. We administered several courses of ECT, which totaled in over 40 sessions. The patient's depressive symptoms tended to remit between courses, as evidenced by the consistently high MADRS score until about session 35. However, his overall catatonia score, measured by the Northoff Catatonia Rating Scale, diminished steadily during treatment, and his cognitive tests improved just as steadily. We had 2 different teams of clinicians administering the cognitive tests, unfortunately. This is why both the scores for the MoCA and MMSE are included here. The other aspect of our study was to measure the concentrations of GABA, glutamate, and acetyl-aspartate, and creatine in the active phase and after resolution of catatonia symptoms. The technique we used for this purpose was the Mesher-Garwood single voxel magnetic resonance spectroscopy. Creatine was used to allow for ratio calculations because its level is generally constant, while N-acetyl-aspartate is concentrated in neurons and it served as a neuronal marker. The results showed decreased GABA in the acute phase, increased glutamate, as well as increased N-acetyl-aspartate. Creatine levels were steady as was expected. And we also saw increased GABA, decreased glutamate, and N-acetyl-aspartate after the recovery. This is consistent with current understanding of the mechanism of catatonia, and also with the fact that benzodiazepines are an effective treatment against catatonia, given that they act on the GABA receptors. That concludes our presentation. Thank you very much for your attention. Enjoy the rest of your day.